Hello, everyone, and welcome to AAKP's Policy Summit, Patient Voice, Patient Choice, New Determinants for Kidney Policy. I'm Richard Knight, Immediate Past President of the AAKP. On a personal basis, I'm a former dialysis patient and 16 years out on my kidney transplant. Professionally, I work as an adjunct professor teaching courses in management and business strategy. Much of my background is in the public policy arena, working at congressional operations based on my experience on Capitol Hill, where I served in various roles, including communication, policy, and as a legislative director. While working in the U.S. House of Representatives as a top aide to a congressional leader, I had the privilege to serve as liaison to the Congressional Black Caucus and was involved in significant policy work with the House Energy and Commerce and Small Business Committees. These experiences have provided me with a framework and a background with a valuable set of skills that I've put to use for AAKP on kidney policy issues over the past decade. However, you do not need to be a professional policy expert to get involved in the policy process. You simply need to be an informed patient. Take the time to study important issues that affect you and your fellow patients, and take advantage of AAKP's free online advocacy engagement skill development training programs. Your voice and your vote can lead to important changes. If you are not a member of AAKP, please join us. Our membership is free. Just go to the link shown at the bottom of the page and sign up today. Furthermore, I want to encourage you to sign up for AAKP's alerts to AAKP's Action Center at the website that's now showing at the bottom of your screen. AAKP will keep you up to date about latest policy issues that affect patient care, and with one click, you will be able to contact your state representative, federal agency leaders, and many more who need to hear your perspective and your unique patient insights. Now, I'd like to introduce our session titled Vital Signals, Kidney Stakeholder Policy Priorities Impacting Patients. We're honored to have 4 individuals who are joining us who represent various organizations that work alongside the kidney community and other disease communities on important policy issues. AAKP is very interested in their perspectives and their views on issues of mutual concern. To get us started, I'd like to welcome a good friend and collaborator to AAKP, Sara Traigle van Geertruyden. She's Executive Director for the Partnership to Improve Patient Care, better known as PIPC. PIPC is a broad-based collaborative of nearly 150 allied patient and disability rights organizations. The chair of PIPC is former U.S. House of Representative Whip Tony Coelho, a strong patient advocate who worked in a bipartisan manner with President George H.W. Bush to establish the Americans with Disability Act 20 years ago. AAKP is proud to work with PIPC to oppose the establishment of anti-patient and discriminatory quality-adjusted life year metrics in federal health programs. These subjective measures, they tend to discriminate against patients with chronic diseases like kidney disease, like kidney patients, because they are used to determine your access to new medications and devices based on their cost and the estimated length of your life. Sara, without further ado, take it away.
Hi, thank you so much for having me here today. My name is Sara van Geertruyden. I'm the Executive Director of the Partnership to Improve Patient Care. I'm excited to be here today to talk to you a little bit more about the use of the metric called the Quality Adjusted Life Year and its implications for discrimination and health equity. So as some of you may know, the Partnership to Improve Patient Care is a coalition that was created way back when comparative effectiveness research was a hot topic in Congress back around 2008, 2009. As an organization, we fought for the creation of the Patient-Centered Outcomes Research Institute an entity that puts patients and people with disabilities at the center of their work and engages them at every step of the research process. PIPC's members were very frustrated that research didn't necessarily include people with disabilities, people with the conditions that were being discussed in the process of designing research. And so what they wanted was research that was really informed and measured the outcomes that they care about. And what they didn't want was for research to devalue their lives and to have implications for coverage that essentially said they were too costly to treat. So as many of you may know, PIPC is chaired by Tony Coelho. Tony was a former congressman from California and is a strong disability rights advocate. He was the original author of the Americans with Disabilities Act, but he's also a patient with epilepsy that comes to these issues with a very personal experience and commitment to making sure that, as the disability rights movement says, nothing about us without us. So we want to talk a little bit today about quality adjusted life years, or as some people call them, QALYs. The quality adjusted life year is a means of measuring healthcare quality. The metric is used to determine whether a treatment is cost effective. And it does that by measuring the disease or disability burden and treatment efficacy and mitigating it. So when you look at the QALY, it'll give a value of 1 to a year in perfect health. It will give a value of 0 to death. And somewhere in between is where most of us fall, especially people who have a disability or some sort of chronic condition. The challenge with that concept is that it will essentially devalue a person's life that's not lived in that optimal health category. So when the quality metric is used, the algorithm essentially assigns a value to the year in the life of, let's say for moderate multiple sclerosis, a 0.5. So the factor by which it will calculate the value of a year lived in the life of a person with multiple sclerosis is 0.5 as opposed to 1, essentially devaluing that life and thereby devaluing the treatment for someone who is living in that state. There are many problems with the QALY. First and foremost, as we just described, the extending disabled life is worth less than extending non-disabled life. But that's not the only problem with the QALY. It also is a process of translating clinical outcomes into utility scores that results in a significant loss of information. So for instance, when it's looking at the incremental improvement in health on treatment, it might be looking at a person who has severe, moderate, or mild conditions. Well, most people don't describe their conditions in severe, moderate, or mild ways. They would describe their condition on different days as being more severe than others. And there's a lot of loss of sort of the nuance of how a person is feeling on a given day or in a given year with the QALY metric. Also, people with disabilities may attach different values to their own health states than the general public. Oftentimes, the health utilities that go into these metrics, they are based on survey data. And as we know, people living with a condition may attach a different value to that condition or to the value of their lives lived with that condition than someone in the general public would. There was actually a very interesting article in Health Affairs recently that I'm happy to share later by Ari Naiman and others, which actually found that there's this tremendous disability bias in the general public, which then would, of course, impact the survey data that goes into those health utilities that inform the QALY metric. Also, QALY-based value assessment is unlikely to account for clinical knowledge on patient variation that's not yet in the research literature. Doctors will often say that they understand how a treatment impacts a patient before the literature necessarily reflects that information. The quality adjusted life year also has significant implications for vulnerable populations. QALY-based models are largely based on randomized clinical trial data that lacks minority participants. That means that their models capture data applicable to white, male, non-Hispanic populations. Without that information, it is impossible for a value assessment then to assess the value of a treatment for those populations that are not part of the database. Also, quality-based models omit attention to the evidence that differential triggers like pollution and food insecurity may have on the expression of disease and illness. As you can imagine, that has significant implications as we're trying to advance a more equitable healthcare system and one that addresses social determinants of health. So the United States has a significant history of opposition to the quality adjusted life year. In the Affordable Care Act back in 2010, Congress included a critical safeguard that was actually supported in a bipartisan way, prohibiting Medicare from using cost effectiveness assessments to make coverage and payment decisions. The prohibition on QALYs was very clearly stated in the statute that created PCORI and prevents Medicare from using that QALY metric as a threshold for coverage, reimbursement, or incentive programs. Even before 2010, when the Affordable Care Act passed, disability rights laws already included provisions that would protect people from use of metrics like QALYs. Section 504 of the Rehab Act ensures that people with disabilities are not excluded from participation in or denied benefits of or otherwise subjected to discrimination under any federal program. And Title II of the Americans with Disabilities Act extends that protection to programs and services offered by state and local governments. After the Americans with Disabilities Act passed in 1990, in 1992, the Department of Health and Human Services actually denied a waiver that was submitted by the state of Oregon that would have used the quality adjusted life year to determine its prioritized list of services. We'll talk a little bit more about that later because that issue is much more nuanced, but it certainly goes to show that there was a sentiment even in the early 90s that QALYs were a violation of these disability rights laws. It's also important to recognize that in the recent Inflation Reduction Act bill that passed, there was also additional language included to further protect people with disabilities. It essentially states that when looking at the drug negotiation and the fair price, the agency is not allowed to use comparative clinical effectiveness research that devalues the lives of elderly, disabled, or terminally ill individuals. Those are their words. So you can imagine the implications for older adults if they were able to use information that essentially devalued life extension for older people. So we also wanted to talk a little bit about the Protecting Healthcare for All Patients Act of 2022. This is legislation that was introduced by several Republicans in the House of Representatives, including Kathy McMorris Rogers on the Energy and Commerce Committee. We are certainly hopeful that this bill may have legs going into next year, as it would extend the QALY ban to other federal programs, including programs like Medicaid, VA, TRICARE, et cetera. It's also important to note that this is a nonpartisan issue. The National Council on Disability, which is an independent federal agency that advises Congress and the administration on disability issues, they drafted a report back in 2019 that recommended against the use of QALYs in federal programs and in decision making. Since then, the National Council on Disability has also recommended a ban on the use of QALYs across federal programs as part of its health equity framework. So some people may ask, why does all this matter? What's wrong with the QALY? How does it translate into things that I care about? Well, the reason that QALYs matter are, number one, the impact on Part B access to care would be tremendously negative for a lot of patients on Medicare. So this particular study looks at certain treatments: rheumatoid arthritis, MS, small cell lung cancer, multiple myeloma. And in this study, they determined that if we were to rely on studies that are QALY-based, particularly by the Institute for Clinical and Economic Review, which we'll talk about, that many patients would lose access to their treatments and have to switch. And the same thing goes for Medicaid. A similar study was done looking at what would happen if the QALY-based cost effectiveness analysis were used as a determination of what Medicaid covers, and similar findings that patients would lose access or have to switch to different treatments. And we see this play out in other countries that rely on the quality adjusted life year metric to determine what they will or will not cover. We see in other countries there are worse outcomes for many types of cancers in particular. We actually have 5-year survival rates that are much higher here in the United States. We also find that people in other countries where QALYs are the benchmark for coverage, they have fewer options for cancer medications. And we also see that their access to newer medications is delayed. So here in the United States, our patients are getting access to newer treatments around 2 years earlier than in other countries. So we worry about cost effectiveness assessments in large part, and particularly the cost effectiveness assessments that are coming out of an organization called the Institute for Clinical and Economic Review, also known as ICER. Number one, they rely on these discriminatory methods such as quality adjusted life years to calculate the cost effectiveness of a treatment, and then to make recommendations to policymakers about how they should cover them, whether they should cover them, whether they should use prior auth and other utilization management strategies, which often, as you know, create barriers then to care. There are also concerns that ICER's studies fail to meaningfully engage expert stakeholders. They don't give them a vote on the treatment and its value. It also fails to consider outcomes that matter to patients and people with disabilities. And this is because if you look at the research literature and you look at a lot of the outcomes that patients will say are important, if those outcomes are not measured in the research literature that is then being used in the value assessment is not measuring things like the impact on caregiving, the impact on someone's ability to sit up in bed, the impact on someone's ability to go to work. Without that kind of information, these studies are not really reflecting outcomes that matter to patients in terms of the value. Also, these studies tend to be very premature, so they're largely relying on randomized clinical trials as a new drug is coming to market. So they don't include any of that real-world evidence that could be gleaned on these outcomes that really matter to patients. There's also a lack of transparency to people who are living with the study conditions, whereby, if you or me wanted to go in and really understand how those calculations were made, it's not transparent and it's not readily available. It's not an open source data system that ICER uses. And yet we're very concerned that ICER is looking to increase their role in healthcare decision making. Some of you may have also read in the news that ICER has been opining a lot on the CMS drug negotiation process that was recently passed in the Inflation Reduction Act. It's important to note that ICER already has a role in Medicaid, the VA, and TRICARE. They're also looking to increase their role through state legislation. A couple of examples: the California Healthcare Foundation funded ICER to generate value assessment and policy guides for use in California. And also, we are currently looking at Oregon and their Health Evidence Review Commission, also known as the HERC, where they're considering options to continue using QALYs and ICER studies in their deliberations related to the prioritized list of services. So a lot of the state-based issues are coming out of an organization called the National Association for State Health Policy, or also known as NASHP. So there's a couple of bills that I think have raised eyebrows because they would exacerbate or increase the use of the quality adjusted life year in state-based Medicaid decision making. So first is Canadian reference pricing, which would allow states to directly reference the prices paid for drugs in 5 Canadian provinces. Before applying for coverage by the provinces, all drugs would have to complete a common drug review by this Canadian entity, which uses QALYs. And then secondly, there's been legislation in several states to create a prescription drug affordability board that would essentially allow the state to review and evaluate the reimbursement rate and coverage for pharmaceuticals. The challenge with those bills has largely been around their reliance on third parties like ICER to come up with the benchmark price. State use of cost effectiveness and value has certainly increased, and I think is raising eyebrows and causing a lot of concerns as they look for one-size-fits-all solutions to reduce their healthcare costs. So in New York, we have long seen their use of the quality adjusted life year as part of their supplemental rebate determinations, which obviously has an impact on the conditions that those particular drugs treat. The ones that we're familiar with here are cystic fibrosis and spinal muscular atrophy. Massachusetts, also, their Health Policy Commission has a contract with ICER to develop their framework for determining the value of pharmaceuticals, despite a lot of advocacy from others that arguing that ICER's models are discriminatory. In Oregon, they did actually renew their waiver. CMS has approved it. And the HERC, as I mentioned earlier, is maintaining that they can continue to use the quality adjusted life year as one factor in determinations related to their prioritized list of services. They're actually taking comments now on 2 options to use quality adjusted life years that are due on November 1st. Also, Washington State's Health Technology Clinical Committee makes coverage determinations for selected health technologies based on the available scientific evidence, and that includes QALYs. So we're very excited too to have template legislation for states to consider that would essentially bar QALYs across the board. Oklahoma is a state that did actually pass a QALY ban, and that has kind of become a standard. And so this is the template for that. So if you have advocates in states that are interested in advancing a QALY ban within the state as part of their legislative agenda, I'm happy to flag for you where to find this particular template, which includes really good language that would achieve that goal. So we're very happy to share with you some resources to learn more. I know that QALYs are a really complicated and complex. It's a complex metric and it's sometimes hard to explain. So some of the resources that we have that might actually be useful for you and your advocates are at valueourhealth.org. The template that I just discussed is also at the valueourhealth.org website. PIPCpatients.org as well. We actually do a weekly newsletter that we would love for you to sign up for. And if you're trying to track what's going on in the states with regard to their consideration of bills that would potentially implicate use of QALYs, we would refer you to patientaccessproject.org, where there's a in real time tracker for each state. It's a very useful tool to follow how states are using cost effectiveness in ICER studies. Thank you for having me here today. I'm more than happy to engage with any of you at any time if you have additional questions about the quality adjusted life year or ICER or what's happening in the states and at the federal level. Please feel free to reach out, and we look forward to doing this again next year.
Thank you, Sarah. Great presentation on a very important issue.